have on the left, we have some mild redness around the connection between a tooth and the gum. And on the right-hand side, that's what healthy gums should look like. So this is gingivitis, the milder stage. The next one is when we're having that calculus. So calculus, remember, is the hotel for bacteria. Some of the bacteria are quite discolored or black, and you can sometimes see them above the gum line, sometimes below. So supra above or subgingival. And once you have treatment for it, you can see how beautiful it heals itself. So there is hope at this stage. However, if we do nothing, then we are looking at what we call advanced periodontal or gum disease. Here you can see that the teeth are out of position. They look extremely long, and they're also quite splayed. You'll see them, the gaps opening up. Now, clearly, as just pure logistics, someone who has gums and teeth like that, they're unlikely to be able to comfortably bite into an apple. They're probably going to avoid any healthy nuts and crisp salads. Already at this point, people are starting to gravitate towards soft food and mushy food, things that are not always as healthy for us as we should be having. So by now we've got a functional problem. So symptoms that we should all be looking out for are swollen and puffy gums, which are red or dusky or purplish. They can feel tender when touched and they bleed easily. Okay, sometimes you'll note after brushing teeth, there'll be a little bit of blood, either in your saliva when you spit out or actually on the toothbrush head. You may or be told that you have bad breath. At the more advanced stages, you may have pus, which is exudate, which is basically dead bacteria coming between your tooth and your gum. The teeth may become loose. You may have pain on chewing. You'll start seeing spaces either on the lower front teeth or the upper front teeth. And you'll see your teeth themselves will look longer, and they may not bite as comfortably together as they did when you were younger. So I'm going to touch very briefly on what I call hardcore science. So some of it may seem a little over the top, but I'll pick out the important studies. So we know that the bacteria are able to move from the inflamed gums directly into the bloodstream. And the effect that they have on this is threefold. One is they have the shared risks. So the bacteria in the mouth is acting as a reservoir for gram-negative bacteria. So remember, these are the bad type of bacteria. And these are promoting the inflammatory mediators. Now, a lot of common conditions have an inflammatory basis, such as cardiovascular disease, which has a link to tobacco smoking, stress, aging. So unfortunately, we pick up more periodontal disease in the older cohort, the older people, race and ethnicity. Now, bear in mind, this is not necessarily a direct correlation. There may be some added component, for example, like a risk for diabetes or heart disease. So that in itself is not a predictor, and a male gender. So we know, unfortunately, males are not often likely to go and seek help for medical or dental problems. So the next one, the studies demonstrating genetic factors shared by periodontitis, so that's periodontal disease, cardiovascular disease, preterm labor, and osteoporosis. Okay, now how does this actually work? Once we brush our teeth, we're removing what we call the biofilm. The biofilm is all the products that are sticking, some of them healthy and some of them unhealthy, to the lining of your mouth and the surface of your teeth. So within 30 minutes from brushing, we already start having bacteria recolonizing the mouth. So the bacteria that are involved with periodontal disease, we also know them as lipopolysaccharides, which essentially is a fat molecule and a sugar molecule which is released by bacteria, these induce major vascular responses. Okay, now what does that mean? Why is it important? So this is the bottom line, which results in platelet aggregation and adhesion. Now, platelets are involved with how thick or thin your blood is and how well you're able to clot, or how you overclot. So clotting in itself can be helpful or harmful if your blood is too sticky. So we know that people with periodontal disease have stickier blood, and this is what's resulting in the cardiovascular changes, amongst some other factors. So it forms the formation of lipid-laden foam cells and deposition of cholesterol. Now, this is the exact same mechanism involved with cardiovascular disease. So if you have a myocardial infarct, a heart attack, this combination of blood platelets together with the fat molecules, lipid-laden cells, and the cholesterol, they go and block the coronary artery, and you end up having a cardiovascular event. So this is a very busy slide, and I don't want to distract you particularly, but there is so much new research coming into its own when we talk about the gut microbiome. So we know we need healthy bacteria in our gastrointestinal system, our colon. We know that if we don't have a good microbiome in the gut, that there are some mental illnesses that have a link to poor gut microbiomes. But we also know that stress, acute and chronic stress, will have an effect on your hormonal system, producing cortisol, that's your stress hormone. And these will have a significant effect in blood pressure, etc. So at the heart of this is that catchword again, inflammation and cytokines, inflammation. So yes, there is a link between stress and periodontal disease. Now, again, for the childbearing cohort or population, low birth weight, the most common cause is preterm labor. Now, they did studies where they took the amniotic fluid and tried to see what kind of bacteria are involved there. Interestingly, there are not by nature these two particular bacteria. So Fusobacterium nucleatum and Capnocytophaga, big words. This is not normally found in the reproductive tract, but they are common in the oral activity. So how do they get there? If you have inflamed gums, the bacteria hop on board the body's circulatory system that it shares with the growing fetus. So we're sharing all the good nutrients, but unfortunately, we're also sharing some of the bad bacteria. And that's essentially the effect that we know at the moment, linking preterm labor and low birth weight. Again, a very busy slide, but it's really just to highlight the clear interaction between periodontal disease and diabetes. And at the heart of that, I want to really you to understand that it's the endotoxins, the dead bacteria that are released into the body, that will trigger the pro-inflammatory cascade. So again, inflammation. And then similarly with diabetes, so AGE, this is a biomarker protein that we find in chronic illnesses like kidney disease, diabetes, etc. So it's a biomarker. We can take some blood and tell us what our risk factors are for the development and the progression of chronic diseases, kidney disease and diabetes in this case. So both of them, there will be destruction of connective tissue. Okay, particularly in the mouth, we also have bone resorption. And for the diabetics, we've got connective tissue degradation. So again, at the heart of this is inflammation. So I think we've done the periodontal disease a fair bit. Let's move on to something a little less doom and gloom. Something we can do something about is tooth decay. So this is multifactorial, and it's always hard to explain how some people can have no sugar and have tooth decay, and some people can have tons of sugar and very little tooth decay. But usually it's combined factors that will play into the formation of tooth cavities. So we need time and exposure. There has to be a substrate, so something for the bacteria to live off, and that's sugar. And then we have the susceptible tooth. Now, what is a susceptible tooth? This is where the age-old dilemma of genetics versus environment, so nature versus nurture. And I have had many patients come in and say, my mom's got bad teeth, my dad's got bad teeth. But I wondered to myself, is it really the genetics or is it the environment? Is it the fact that the children have grown up with a lot of sugary drinks in the fridge? Hard to say. But when we're talking about the susceptibility, some people have a tendency to low volume saliva. So if, for example, you have drugs or a condition that's going to drop your saliva flow, that will increase your risk. The other thing that will increase your risk is the quality of your saliva, how well your saliva is able to buffer the acid caused by sugar, because we know bacteria grow in an acid environment, and sugar and the fizz, even diet cola has a fizz, and the fizz will form an acid environment, and in this environment we know that the bacteria can proliferate, grow, and cause tooth decay. So this is primarily why I'm still in business, all right? And it's such a shame that I'm from South Africa, and when I was growing up, myself and all my little friends that I used to play with, we just did not have, I don't know, maybe the income or the knowledge of all these fizzy drinks. And I'm very grateful to have been brought up with very few of these fizzy drinks available to me. However, as people become more affluent and as we move out of absolute poverty into relative poverty and then, you know, improve quality of life, we have slightly more money to spend on things. And sadly, we're spending often on things that are not good for us. So absolute poverty is probably not bad for dental health because we just don't have that level of sugar intake. But I'm not an epidemiologist and I'm not going there. Primarily, stay away from these drinks. Even the diet fizz, the diet drinks are very harmful for your teeth. The other thing is sneaky sugars in all of our, so many of our cereals that we're feeding our children, myself included. You know, I've got 3 children and I find it hard sometimes to eradicate these hidden sugars from their diet. So this is an older term, but I do like this term and I'm going to use it today. It's called baby bottled caries. Often when children are walking around with sippy cups or bottles with sugar, fruit juices, milk, or even, you know, heaven forbid, fizzy drinks in a bottle, you can see the effect we've got here on the enamel that's completely eroded, and then we've got clear tooth decay right throughout. Okay. So unfortunately, it doesn't only affect the children, it affects adults as well. Sadly, this level of tooth decay is more often involved with people with either significant mental health or addiction issues, because it takes an enormous effort to get your teeth looking this sad. So that's obviously tragic. So I'm going to link a little bit of public health at the moment, because it's really important to understand the effect that these conditions and tooth decay have on our general population. So this is Public Health England. The average cost of an extraction in hospital for a child aged 5 and under is £836. I think this was possibly maybe 3-4 years old, so clearly it's increased. And you can see how many millions of pounds we're spending on, in most cases, avoidable tooth extractions. But before we take teeth out, these poor little children often have infection and pain. And I'm so sad for them because they've had very little choice in it themselves. So little Johnny at 6 or 5 years old is not going to be able to make the wise choice. And we cannot blame the children. We cannot blame the children for our faults, okay? So this is where we and the adults have to step in. Just to give you an idea, children may miss school and parents have to take time off work because of serious dental pain and swelling. We know that a huge number, 46% of 15-year-olds have tooth decay. And this is where things start becoming a little bit more worrying. There are 26,000 plus hospital admissions due to dental infection and infection. And these children are likely to go under general anesthesia. Now, for all of us who have had to have procedures done or whose family have had procedures, general anesthetic is not a risk-free procedure in itself. Okay, so we are increasing our children's risk of real harm by not looking after their teeth. The other thing we were saying that we can pick out here is that 42% of children did not see an NHS dentist. Again, statistics can be misleading. Maybe some of these children have been seen privately. The statistics are not as robust for private dental care because it's not a particularly unified statistical database. But we know 42%, this is not negligible, have never seen a dentist. Again, on the lower right, 61% increased hospital admissions over the last 5 years. So I read most interesting statistic in Glasgow, again, a very low deprived and socioeconomic area. They are doing as many dental extractions on children now as they did pre-World War II. So it doesn't matter how much knowledge we have, if we are unable to implement that knowledge, it's always tragic. I'm not going to delve too much into this, but there is a sad correlation between NHS dental charges and dental access. This was taken in May 2021. So, I mean, this is just weeks old. And it says 1 in 3 have reported they felt pressured into private fees. 27 have struggled to pay their dental treatments. But the bottom line is demographic groups have been affected differently. And those with the highest risk with COVID, so we're talking about the minorities, have been are the ones that are likely to avoid dental treatment. Okay, so there's a bit of a correlation at the moment between income and regional disparities. Sadly, the northeast of England reports the highest levels of tooth decay, and sadly, they are likely to be the ones that are least likely to go and seek help. So just over a quarter of people from ethnic minorities reported that they would go to the dentist for regular checkups. So this is not for pain, this is just regular preventative work. So 26% would go for routine care versus 41% of the white population. So the interesting group is those are over 55. Now I wondered to myself, I'm heading closely to this figure here. I don't know if we just so weighed down by the financial responsibilities of, children at university, the mortgage, real life stresses, that we may brush under the carpet something that we think is non-essential. So I kind of understand this in some ways. So this is my view on the solution that we can outline. The truth is, each of us have to take ownership for our own dental health. Almost all dental disease is preventable, and information is freely accessible to everyone. So it's often the simple things that are the absolutely vital things. So proper toothbrushing, good toothpaste, and good diet is affordable to all. Now, I worked in my very beginning years in Aberdeen, Grampian, and there are significant parts of Scotland which are deprived. And one patient said to me that it's cheaper to buy a packet of white bread, crisps, and a fizzy drink instead of blueberries, strawberries, and granola. And in many ways, they're right. However, I do think that if we have the motivation to seek out healthy, affordable options, I think this can be addressed. And it may be something as simple as, you know, Lidl or Aldi. They have beautiful fruit and vegetable sections that make the healthy things affordable. It may take a little bit of relearning to cook with simpler ingredients, with maybe less sugar. But what I'm trying to say is that it's not out of the reach. It takes as much effort and money to buy rubbish for our children as it does the good things. The difference is choice and motivation. So we are not spoiling our children, in other words, treating them. Sorry about the noise, people. When we buy them sweets and fizzy drinks, the only thing we're achieving is spoiling their teeth. So extreme tooth decay is a form of child abuse. Pain and infection, which can be life-threatening to some of these children, is avoidable. So prevention, early detection, and appropriate treatment is really the kingpin of modern medicine and dentistry. So parents, we have to be strong. So until these little children are working and have their own income, we are responsible for what they put in their mouths. We do the shopping, we buy. And I'm talking to grandparents, I'm talking to aunts and uncles. We may want to treat our grandchildren or our little nieces and nephews when they come to visit. But remember, we may be spoiling them in the wrong way and really exposing them to pain and infection that we could avoid. And very simply, you know, parents who say, oh, but my son, you know, is so determined to have sugar. And I want you to remember, and this is what I tell my patients with their children, we would not buy something harmful for a teenager like cocaine. So similarly, we shouldn't be buying sugar for our children if we know it's harmful for them. Okay, so I did touch on the genetics versus environment. And you know, the old little saying of my whole family have bad teeth versus mom has always bought sugar with cereal, or we always have cola in the fridge. I hope you hear the difference. So we can't blame our genetics always. We have a role to play. So why do we go to the dentist and what do they do? We recommend a dental check twice a year. Why? So that the dentist can check any draining dental infections. We examine your lymph nodes. We look at your jaw joint to make sure that the mechanism, the hinge work is working well. You're not clenching or grinding or having any arthritic changes. We're looking at the lining of the inside of your mouth. We do a cancer check. We don't like talking about it, but it's important. While I'm on this topic, I'm going to spend just a minute talking about cancer, mouth cancer. We know that 1 in 50 cancers diagnosed is oral cancer. And sadly, it's often men over 55. However, there has been a significant increase in younger people having oral cancer for a number of reasons. When we're talking about cancer generally, the survival rate, which we term in a 5-year survival rate, in other words, how aggressive is this cancer, how likely you are to die from it, the mortality is quite high for oral cancer. It's about 55%. So this is far worse than breast cancer or even prostate cancer. Okay, and bear in mind, the treatment for mouth cancer is so deforming. We're chopping people's tongues out, we take their jaws out. It's horrible. It loses our identity as a human being. So it's not a lovely, it's not a good thing to gloss over, and we don't like talking about it, but it's important for us to understand. So the other thing your dental check will cover is how well your gums are. You diagnose and manage all dental disease. Now, in most practices now, we have a dental hygienist. They are so vital and so important. And sadly, they're still not common in national health practices. But I would say that they're 50% partnership in gum health. Actually, no, 3. So a third by the dentist, a third by the patient, a third by the hygienist. We have to work together for this one. Dentists will diagnose and treat tooth decay. And the quicker we diagnose it, the earlier we diagnose it, the less invasive the treatment the more pleasant the treatment, the cheaper the treatment. So a stitch in time saves 9. I'm sure we've all heard of that statement. And this is a very clear case. So we can give you the very best advice about prevention of tooth decay or gum disease. And in this day and age, we're spending so much time on Zoom, and we all want to have the lovely Hollywood smile, but we can certainly help people enjoy a confident smile with fresh breath. So we're going to look a little bit at the factors that may affect this. Smoking, sadly, although is slightly on the decline, we're having an increase in the non-cigarette vaping type of exposures. We just don't know the effect of vaping on the body yet. So time will tell. And I think it's important, in my mind, to treat it very similarly to regular cigarette smoke. Smoking and drinking together increases the risk of mouth cancer by 30 times. So it has a very known synergistic effect. Smoking alone increases your risk, but together it makes the lining of your mouth particularly unstable and a particular risk for mouth cancer. I'm going to just spend a moment going through this, but there is national health dental provision on a primary, so that's your primary general dental practitioner, on a secondary and a tertiary level. Everyone needs a general dentist, be it a national health one or a general dental practitioner. And for some reason, everybody feels, I think it's because of the structure of the national health access. When you go to A&E, the first thing they ask is, which GP are you registered with? Sadly, it's not the same importance as a general dental practitioner. So a general dentist can refer you on to specialist services. We know the referral routes. For example, if you have an oral condition that needs a biopsy, so we think there may be some type of unusual changes, or if you have a wisdom tooth that needs to come out, or an unusual pain condition, we can refer you forward. Unfortunately, with COVID, and even before COVID, we have the decades-long dilemma of long waiting lists and a significant need for the service. So unfortunately, that is something that's getting worse in the short term and not better. There are private referral pathways, but I really want to touch a moment on this. Private general dental care in the UK is not necessarily out of the reach of an average person. And I say this with meaning. I work in Edgware in a private family practice, and many of our patients are people who you would never assume would have private dental care. We have many construction workers, many foreigners, just many people from all walks of life. But if you have a low dental need, it's never, you don't have to spend huge amounts of money. And we have these monthly payment schemes. Almost every private practice will have a monthly payment scheme. So this is something that can help spread the cost and make that a bit more affordable. I'm going to touch a little bit on different, we're leaving the general dentistry behind in some way. And this is my specialty, my field. It's called trigeminal neuralgia. I'm just looking at your time. Oh, we're a bit over time now. Mr. Shah, I don't know if you want us to sort of stop right here, or
no, I think we can. We are okay to continue. It's 1:10. We are okay to continue.
Okay, fantastic.
Yeah. It's very interesting. So let's continue.
Okay, I've left the interesting stuff till then, have I? There's a condition called trigeminal neuralgia. Essentially, I think this slide shows it all. It's often in older people. There's a slight increase in females, for example. And the words that people use to describe this pain, they say it feels like an electric shock, an ice pick. It feels like it's burning. It's a really, really horrible pain. And it's been termed as the worst pain known to mankind. So in my clinic, my NHS pain clinic, sadly, I treat a number of our patients with this condition. What is it and how does it manifest? So essentially, it'll either be usually on the second part of the facial, the trigeminal nerve, or the third part. So it'll affect the upper teeth, lower teeth, lip and chin, and sometimes the cheek. Very, very rarely the eye and the structures around the eye. Now, the way I explain it to my patients, we all know that electricity and water cannot mix. We know that. So if we had a water pipe and we had an electricity pipe, if the insulation between them was worn away, or if they communicated at all, then we know we'll have some spark disaster. This is just in normal DIY terms. In the human body, if we have the nerve, which is called the trigeminal nerve, and a blood vessel, if the blood vessel pushes down on this trigeminal nerve, it can form these stabbing shock pain that people are experiencing. It affects them in the inability to eat, talk. So you'll be having a conversation and suddenly they have to stop mid-sentence because they're having an episode or an attack, as we call it. So this is where technology is coming to its own. Many decades ago, all we had was what we call plain imaging. We knew something was happening in someone's brain with this condition, but we couldn't see very clearly. We then moved on to something called CT, computer tomography, and this is invaluable for anything to do with bone and bony structures. However, when we are managing our patients with trigeminal neuralgia, we're sending them for something called a magnetic resonance imaging of the brain. And about this level here, so about there, just behind the ear, on the left, you'll see that little arrow. That's where that blood vessel is pushing down on that nerve. This is called compression or conflict. So there's different strengths of MRI imaging that we use. There's T1 and T2. This is how strong the magnet is. And the stronger the magnet, the clearer we can see, the more detailed we can see. Now, London has just acquired its very first 10.5 Tesla scan. This is primarily used in the university and research centers, and we each have to pay a fee for our patients to undergo this, and it's mostly for our clinical trials. However, I want you just to see for a minute the clarity between this previous imaging compared to this beautiful image here. We can see so clearly. And why is this important? Because we need to be able to manage these patients. My role is to medically manage. So I give prescription drugs, very, very debilitating drugs, but without them, these patients will have no quality of life. And most times, for about 10 to 15 years, I can manage them with medication. At some point, now this point is different for different patients, they may need the services of our neurosurgeon at King's. His name is Sinan Barazi. He is amazing. And they do something called microvascular decompression. Essentially, they go and find that nerve. So here's the fifth cranial nerve, the trigeminal nerve. And they separate the artery from the nerve, because we know if they're lying closely together or compressing or pushing each other, that this patient will experience pain. However, if they can dissect that away and they put a little felt pad or Teflon pad, this patient will go from stabbing pain to no pain within immediately post-operative. So this is life-saving surgery for the people who will benefit from it. And there's often a little scar left behind the ear. This is major brain surgery, and we don't embark on this lightly. I think the other major progress we've made, even as a surgeon, as well as a dentist, we often use what we call loops and magnification. So years and years ago, when I first started, I never needed anything except maybe protective goggles. And now, routinely, I'm using these lights as well as magnification. To give you an idea of how much clearer we can see, we go from an actual size to a 4.5 magnification, which is a huge difference. So both dental and medical colleagues are using this. It really helps us. If you can see something, we can do a better job. The next sort of big leap in dentistry that I have seen in my professional lifetime. This was the gold standard as imaging went as a young dentist. This takes an x-ray of the entire mouth, and it puts this essentially into a 2D image. We cannot see behind, we cannot see in between roots, but it gives us a very good global overview of what's happening with our mouths. For those of us placing dental implants or who've had specialist root canal treatments, we now can see entirely around the 360 of a tooth. We can see the tooth in relation to the nasal floor. We can see the tooth in relation to the sinus, the maxillary sinus. And especially for me as an oral surgeon, where this tooth is in relation to important nerve structures, so that when we put dental implants, for example, we're not damaging a nerve. The other thing we're using it for is, so that is called cone beam CT scans. Again, it's a very low dosage of radiation for the quality that we have, but it is bigger than the normal dental x-ray that you may have at the dentist. We're using it also in facial trauma. So as a young surgeon, I had to do a lot of trauma work, and we started seeing images like that, which was very cool, but we never always had an application for that, other than we could maybe plan our surgery. However, now we have 3D printers, and if we're having significant surgery for a very extensive facial fractures, for example, the computer will print out all the fracture fragments, and then we can do pre-surgical planning where we bend all of our wires and our screws. So instead of surgery taking us 6 hours to put someone's face together, we can now do it in 2.5 hours, and with a better outcome. So this is how technology's helped. This little the blue sheet here, at the moment, a lot of conditions sadly require us to have access to the cranium, the skull, and we can't always put it back, or if it was hurt or damaged during trauma. We now can use different materials, biocompatible materials, and we can print this out perfectly and replace someone's skull partly with these materials due to 3D scanning. So when I first trained, this was the new thing. It's become far more common. Unfortunately, 1 in 700 live births in the UK are cleft lip and palate, and some of these children will have facial anomalies where their lower jaw, their upper jaw rather, is very, very narrow and far behind the lower jaw. We're using this now to grow bone. It's called osteodistraction. So we separate the bones from the skull, and then we attach this to the frame, and the patient has a key, and every day they're turning this key 0.5 millimeters, for example, and this will allow the growth of the upper jaw or the growth of the forehead, depending on what the condition is. Years ago, we did not have this technology, and we'd have to then go in when the child stopped growing and then do jaw repositioning surgery. So this is jaw correction surgery, also known as orthodontic. The goal of orthodontic surgery, and most, it's not a cosmetic procedure, and I say this again. Essentially, we're putting the outliers, so people who look markedly different, we're putting them into the herd. So we're taking the hideous and we're putting them into the herd. We want them to look more or less everyone else. So this young lady had significant problems with a lower jaw that was very, very retroclined. And the surgery was repositioning of her lower jaw, bringing it forward. So essentially, we'd break the jaw, move it forward, and repositioning it. And I think we'll all agree that the profile of the young lady on the right is far different to the one on the left. But I gave this talk in a variety to my daughter's school the other day. And I think we should say this to adults and children alike, is it's still the same young person living in the same, in this body. So the left person and the right person are still the very same. And it's such a shame that we treat people differently when they look differently. You know, it's very simply, we stare at them, we avoid talking to them. We think for some reason that there may be some cognitive problems, when very often it's just a physical appearance, which thankfully now we can change. So when I started doing this surgery, we used to do tracing paper, We'll take this x-ray on the left and we'll put regular tracing paper. And based on this, we'll decide how many millimeters we'll advance the jaw or we'll push it back. And now we're using 3D modeling where we can show someone more or less what they'd look like after the repositioning surgery. So that's been very exciting. The next thing that has changed is dental implants. People lose teeth for many reasons, some due to gum disease, some due to dental neglect. But we now have the technology to replace it. Years ago, all we had were dentures. Now, I remember seeing my granny's dentures and I was terrified of them as a child. Did they work to a point? Do we need them? Yes, we need to have a presentable smile, but not only above aesthetics, I think we really have to mention that function is important. Again, we want to eat healthy food, nuts, salad, you know, really good quality proteins, for example. So many years ago, when you didn't have enough bone, we used to say, sadly, we can't help you. Now we're doing some rather adventurous, and I did a case like this not long ago with a colleague of mine. This is called zygomatic implants. Now, the technology used in this essentially came out of the technology needed to reconstruct people's faces after cancer surgery. So we can do an enormous amount now replacing people's teeth. Now we do onto the nicest and the more sort of fun bits of dentistry. We are doing a lot of tooth whitening as a profession. And again, is it an Americanized cosmetic drive? I don't think so. A lot of us are spending a lot of time and effort trying to keep our teeth healthy. And it doesn't mean white teeth are healthier teeth, not by any means. But if there is a harmless way and a straightforward way to lighten and brighten our smiles, we all know as we age, our teeth get a little darker. It's such a joy to see someone smile more when they have something to smile about. So this is, we used to think a lot of it as just purely cosmetic. I don't think so. I think it's a confidence builder. This is the other thing that gets me up with great joy in the mornings. This is what I do a lot of. I do a day and a half, well, at least a day of this per week, is orthodontics. Now, modern orthodontics, if you've had children or family members who have had braces before, they would typically wear braces, fixed braces, little brackets on teeth for up to 2 years. The technology has improved so beautifully that we can talk about days instead of months and years. And I say this meaningfully, hand on heart, this technology works incredibly quickly and well. And I'm just going to spend a moment and say why it works so well. The inventor in America, he had the ability to play with a big research computer model at his university. And he was wondering what forces are involved when a tooth, when you're a child, pops through the gum and then goes into the correct position. So he analyzed the forces necessary to erupt a tooth. And it turned out the forces were quite gentle, and a tooth normally took around 3 months from the time it poked itself through the gum to the time that it was in full position. And he thought, what would happen if I mimic the forces of nature? Would it be slower or faster than conventional braces? And it turns out that it works incredibly fast, but the forces needed are incredibly low. And that's where the technology comes in, is using gentle forces to mimic Mother Nature's eruption pattern. And I think this is very exciting for anyone who, as an adult or has children needing orthodontics. It's lovely to be able to offer someone a meaningful solution in 3 to 4 months. And this is where it becomes a little bit more research and a bit futuristic. At my university, I was involved with a trial where we used to take our baby teeth in theatre, and we used to keep the stem cells that we know are present in these baby teeth. And we use these stem cells to see if we can grow teeth. So we have till now been able to grow certain parts or up to a certain stage of what we call the tooth bud. So this is the beginning stages, like you have the embryo when a tiny baby is like a cashew nut growing all the way to a full fetus. Again, we have this tooth bud, which over time and special development will develop into a tooth with enamel and dentine and a nerve structure. So we're at the moment, we're getting some hints of tooth bud formation, but not quite yet. I think this is a more realistic picture. This is stem cell biology. The other application of this is quite remarkable. In the UK at the moment, they're doing something called placenta harvesting or stem cell harvesting. So once you've had a baby, you can sign away and give your placenta to a placenta bank. If a child needs stem cells for leukemia or for certain cancer types, blood cancers, they then look for the tissue type and they can match this. And they find the same stem cells now in baby teeth. If you have a granddaughter or grandson who's losing the baby teeth and you want to hedge their future chances of cancer, you can store their stem cells. There's certain labs that will store this for you. And if, heaven forbid, you need them, you then retrieve your own stem cells and you can then have treatment for your oncology, whatever blood oncology you may suffer with. So yes, we can do, we're starting to grow teeth, but also we're harvesting stem cells that we're storing from baby teeth and some adult teeth. And I think this is the end of my talk. I'm going to hand this back to Mr. Shah.
Thank you so much, Leigh-Ann. That was so useful and so informative. I've got a few questions, and if I can ask you the questions.
Sure.
Okay, in no particular order. So the first one I have is it best to rinse your mouth after having every meal? Would that help?
The long and short of it is yes, because within 30 minutes of a meal, the saliva flow is significant enough to neutralize an acid. So rinsing your mouth is fine. Equally, you could chew chewing gum because that will, again, increase your body's own saliva flow. Or you could use a fluoride mouthwash. So there's a number of ways to do this. Essentially, you're just wanting to reduce the acid environment so that you can reduce the likelihood of tooth decay. But I feel I should just quickly mention that it's not necessarily what happens after a meal that's important when we're talking about tooth decay. It's what happens between a meal. So say, for example, I'm sitting here with a cup of coffee. I've been here for about, let's say, an hour, and I'm having a little sip for an hour and a half. If there was sugar in my tea or coffee, I would be having repeated acid attacks on my teeth. If I had the same cup of coffee at the end of a meal, it would have no effect on tooth decay, because within that half an hour, my saliva would have neutralized the sugar. So try and avoid sugary things between meals. That's more important than rinsing after a meal. I hope that answered your question.
Thank you for that. Next question is, if dental health is so important, why do NHS patients have to pay for a hygienist to clean the teeth and gums?
The way I'm explaining it to people is, if there is one finite pot of NHS money, and you had to balance that between having treatment for diabetics, a heart transplant for a baby, or tooth cleaning by a hygienist, I think the powers that be will prioritize according to what they see as the highest need. I agree that this is the tragedy currently, but without the hygienist, if you think that a hygienist is about as affordable as a haircut, and we do not ask the government to pay for the haircut, I'm just going to leave it with you at that. Now, I can say this because I'm a dentist. because I know how to clean my teeth, I actually don't need a hygienist. I'm not saying what your dentist will advise how frequently you need the hygienist. And I have some people who go once a year on my prescription because they're doing such a fantastic job that they're fine for an annual treatment. So I always have to ask someone, if you had to choose between a hygiene visit and a haircut, that's a tricky decision, but there is a finite pot of NHS money. And I would like to know that my baby's able to have a heart procedure, because I can maybe afford, hygiene care. This is almost a political issue. I'm sorry if I didn't answer it particularly well, but that's my view, at least. Sorry.
Thank you, Leigh-Ann. The next question is quite an interesting one. So somebody's asked, the person's got Sjogren's disease, who visits the dentist regularly. Is there anything that is available for dry mouth for somebody who's got Sjogren's?
There are a number of medications and saliva replacements. There are so many. And essentially, once they've been diagnosed with Sjogren's disease, they will have access to an oral medicine service. Guy's has an incredibly good salivary gland service. And based on that, they will go through a whole regime of different types of saliva replacements. So some of them, the best actually I've found come from the States, if I must be honest. But there are many, many saliva replacements. With Sjogren's disease, I think the most important thing there is they can do really good tooth decay prevention. So when you have no saliva with Sjogren's disease, you're at very high risk of having extensive tooth decay, not because you don't care, because essentially the saliva is quite protective. And if we lose the saliva flow, we're at risk for significant tooth decay. So there are ways of managing that as well. So oral medicine, they have a whole regime. It's quite extensive. And if you want, you can just send me an email. I can directly email someone back regarding salivary replacements. But I think the bottom line is whoever diagnosed you should have a management plan in place for staged saliva replacements.
Thank you, Leigh-Ann, and I'll pass your email address to that person.
Sure.
Okay, the next question I have is dentists and probably opticians as well can often detect early signs of a disease. Why is it that the profession is not working closely together? So medical records available to dentists, dental records available to GPs. Is there any reason why that is not happening?
Wow, that's a very loaded question, isn't it? I think the national aim over time is to correlate the services of the national health together with dental optometrists, etc., and to make that accessible for the patients. So that is the national goal over time. But unfortunately, there's always been a bit of a historic divide. And I was just speaking to my friend, the head of Watford eye department, and it's such a shame that often when we refer patients either as an optometrist or a dentist to a big center like the Eastman or King's where I work, there's very little feedback on the condition that the patient essentially will be diagnosed with. But essentially, when you are sent to a tertiary hospital, they will then write back to your GP. Well, I certainly do for my patients. So the GP is probably best placed to collate the general medical records. But I agree, there should be significant communication between specialties, particularly dentistry and optometry. I don't know if that answers your question. I'm hoping it does.
Yeah. Thank you, Leigh-Ann. Another question. Why is it extremely difficult to find NHS dentists? Most of them are willing to give private treatment. Is money the motivator?
Oh, what a brilliant question. Enormously important question. There's The contract that was installed in 2006, prior to that, was a fee per item. So if you needed a filling, you get paid, you did a filling and the government pay you for a filling. In 2006, the contract changed enormously, and the dentists didn't agree with this in principle. But what they said is, you have three bands of treatment. So one is the low risk, low treatment need. The tier 2 is a medium risk. So for example, whether you need 1 filling or 10 fillings, the NHS will pay you the same. And then the third one is if you need extensive crowns or bridges or dentures or something. So these are called units of dental activity, and the government centrally will allocate X amount to a practice, not a practitioner, but a practice, usually practice owner. And let's say, for example, I'm allocated 1,000 units of dental activity. That should last me a whole year. However, I have no real prediction of what my patient's needs are coming to me. So if my patients need 1,500 units of dental activity, essentially, I would be getting nothing. I'll be paid nothing to treat that. Now, as much as we'd like to help the next person, running a dental practice in itself without, this is national health or privately, is something in the region of £250. Sorry, I'm lying, £125 per hour. So that's with our insurances, the nurses, all our protection, all your protective wear, the materials, etc. So we cannot afford to run at a loss, as it were. And the government are not providing more UDAs. You have to then tender if you want more. And they've discouraged increase of units of dental activity provision. So your dentist, I haven't personally worked as a general dental practitioner in the NHS system for, I think, 18 years. But I think that's just because I always want to. I'm not saying that national health dentistry does not do the best always, but I absolutely hate the idea that some pen pusher somewhere is telling me what I cannot do for my patient if they need something. So there's a lot of politics. And the reason why there's not so many national health dentists out there is because these units of dental activity are becoming far more difficult to allocate, or the tenders are not being given out centrally. So that's the bottom line. And also it varies wildly. So in London, a unit of certain parts of London, a unit of dental activity can be £12. And in some of, say, Cambridgeshire or Oxfordshire, it may be £28. So there's a lot of variables involved with this. Yeah,
Okay.
Not ideal. I appreciate.
Thank you, Leigh-Ann. Next question: how does alendronic acid affect your gums and teeth?
Brilliant question. Alendronic acid is often given for people with osteopenia. And there are these are a group of drugs called bisphosphonates. Bisphosphonates are given either as an oral tablet or as an injectable infusion. As an oral tablet, they're most likely to be used for osteopenia. So that's the stage just before osteoporosis. Osteoporosis is usually intravenous infusions, as is treatment for metastatic cancers like breast cancer, lung cancer, and prostate cancer. Essentially, it modifies the bone biology. What happens is it slows, in normal bone health, you have to break down some bone and you have to build up some bone. That's normal bone turnover to maintain a healthy skeleton. So this balance has to be kept in an ideal ratio, the breaking down and the building up. That's healthy. When you have osteopenia, you've had more breakdown than build up. So what alendronic acid and the bisphosphonate does, it slows down the breaking down so that it's building up. So you're having more dense bone. Now, when you're having more dense bone, essentially it becomes less vascular. So it cannot heal so well. So when you have a tooth removed, when you're on bisphosphonates, you're at very, very real risk, depending on your condition as well as the type of bisphosphonate that you're on, you're at risk of having your jawbone dying. It's called necrosis, death of jawbone, simply because they've slowed down the breakdown, but we do not have the healing vascular properties in the bone. So you cannot heal. If you cannot heal, the bone dies. It becomes there's very little healthy blood flow. And that's why we're at terrible risk of not gum disease per se, not at all, but the risk is when you're having teeth removed. So that shouldn't affect gum disease, and it shouldn't affect tooth decay. If anything, if you're on bisphosphonate, you have to have excellent oral hygiene and minimal tooth decay, because if a tooth becomes unrestorable, in other words, we have to remove it, the risk of jaw rot will increase. So the bottom line is take extra care of your gum health and your dental health when on bisphosphonates.
Okay, thank you. Next question, what is the best option for sensitive teeth?
Great stuff. Firstly, there should be a great advert campaign saying spit, don't rinse. Now explain it to the women because we understand this. It's like buying the most expensive anti-wrinkle cream that costs £30 for a tiny pot, putting it on and rinsing it right off. A toothpaste may be amazing, but it can only have effect when it is in contact with your teeth and gums. So the rule is spit out your toothpaste, wipe your mouth, do not rinse afterwards. So that's the first thing you can do. The second one is you can treat your toothpaste like an ointment. So if, for example, I've brushed very hard just here and it's really sensitive, I can use a toothpaste for sensitive teeth, and I can use it multiple times a day, like you would an ointment, and you carry it in your pocket and you just rub it on that tooth. And within a week or two, that will desensitize beautifully. The other one is you may have sensitivity if you have tooth decay. So you must get it checked out. If you have extreme sensitivity, then we can use very special high fluoride toothpaste, and we make a special mouth guard for you to put this toothpaste in. It's called Durafat. It has 5,000 parts per million of fluoride, and you wear that overnight, and we have the best response with that modality. So it's a staged approach, and yeah, I think that should answer your question.
Perfect, thank you. Next question is, I think the person may have missed the initial part of the talk, but if you can briefly explain, how does tooth decay cause stroke?
Tooth decay doesn't cause stroke. Again, it doesn't cause stroke, but gum disease has a significant link to cardiovascular disease. And the way that works is your body is fighting an inflamed gums, and the bacteria basically hook a ride in your bloodstream. And once they're in your bloodstream, these bacteria and inflammatory byproducts increase how thick your blood is. And when you have thick blood, you're going to have strokes and cardiovascular and heart attacks. So anybody who's had a stroke or is at risk of a stroke, the first thing they do is they put them on antiplatelet drugs or blood thinning agents, things like aspirin, or things like, NOACs, the new oral anticoagulants, or they put you on warfarin. So these are essentially, we know that thicker blood is going to cause strokes and heart attacks. So that's the link between gum disease and strokes. They have common inflammatory changes that are the trigger. And then the more difficult, the more complicated kind of biology is that the bacteria release inflammatory byproducts, and these inflammatory byproducts are mixing with cholesterol. So these are these fat lipid molecules, and they together in the bloodstream with these more sticky platelets are going to be clogging your arteries, and that will predispose you to cardiovascular incidents, stroke and heart attack. So it makes your blood thicker because it's chronically inflamed.
Okay, thank you. A couple of questions left. The next one is, how do you avoid grinding of teeth whilst asleep uh, as this will thin the teeth eventually?
Oh, brilliant question. So the drive of daytime grinding and the drive of nighttime grinding, they have a different cause. Nighttime grinding is a movement disorder of sleep. It's a bit like restless leg syndrome. I don't know if you've ever seen people that just cannot get their legs to keep still and they're wobbling their legs all the time. You almost have no conscious control over that. Yes, there's some links between that and poor sleep. So if you have a breathing disorder of sleep, if you snore or you have obstructive airway disease, we know that you have increased chances of clenching and grinding, but primarily it's a subconscious habit. In the daytime, you can make conscious effort to stop, but at nighttime, you can't. So often you can go and ask your dentist for a mouth guard, something called a bite raising appliance. And the function of these bite raising appliances is threefold. One is it acts as a physical barrier. So it stops the tooth and the other top and bottom teeth from wearing each other thinner. So that's one thing. Secondly, it provides a barrier so that your brain can try and interrupt the subconscious loop of clench, grind, clench, grind. So it tries to slow or block down the subconscious habit. And then the third thing is, if you clench and grind a huge amount, the jaw will essentially normally has a disc in between. If you grind it to such a degree that you'll end up with bone on bone wear rather than having the disc in place. So when you're wearing a mouth guard, it separates the disc space just enough for your disc to sit comfortably where it should be. Otherwise, you're clenching and you're grinding and you're wearing that disc away and you'll end up with bone on bone wear. So bottom answer is it's almost impossible at nighttime. Daytime you can.
Okay, thank you. There's one more which has just come through. Does flossing improve if your mouth is smelling?
Yes, but when people come to me and their primary problem is halitosis is a very fancy word for bad breath. The biggest cause is what we're eating. So I had a lady come in and she said, "Oh, everybody's complaining of my bad breath." But what they forget is what we eat is really going to drive a lot of that. So she loves hummus. Hummus, as you know, has got a lot of garlic in. Garlic is one of those things, garlic, onions, etc., that are going to be precipitating the perception of bad breath. So the first thing is, if you're really worried about the smell, watch what you're eating. Secondly, brush your tongue. And then thirdly, if as long as you don't, flossing is a combined effort in helping to keep your teeth and gums healthy. So flossing alone is not going to solve your bad breath problem, but it's certainly going to help. Certainly.
So you spoke about brushing the tongue, but there is something called scraping the tongue as well. Using the scrapers.
Tongue
Would you?
scrapers.
Yeah.
That's really interesting. I know a lot of Indian people do have tongue scrapers. It's fantastic. Personally, I use my toothbrush with a bit of toothpaste. Whether it makes me feel good, maybe it tastes better, I don't know. But I think they work equally well. One just has the toothpaste element and one doesn't.
Okay.
But they each work quite well.
Perfect. Perfect. Let me just make sure. I think we've done all the questions. There are no other questions in the chat as well. So I think we are coming to the end of the session. Leigh-Ann, I'd like to say a big thank you to you, and also thank you for being our family dentist. I
I'm
really do appreciate it.
delighted to be your dentist. I enjoy seeing you and your wife and your young ones. And thank you for allowing me to talk. It makes such a difference. All I ever talk to is pain specialists and undergraduate kids trying to take teeth out. So it's lovely to speak to a wider audience. Thank you so much. I think someone, Vipin Shah, has their hand up. I don't know anything about how to manage a
Okay.
Zoom thing, but
Right. Okay. Right. Let me ask Vipin Shah to unmute, and then he can ask the question. Vipin, do you want to ask the question?
I'm going to pass it on to Vin. I'm just going to ask the question. Thank you.
Sure.
Hello. I just wanted to know, how do you treat geographical tongue?
Geographical tongue. Essentially, we don't always know why someone will have geographic tongue, but geographic tongue may sometimes be linked to some deficient. Officially, they say it's not, but there is some tendency to see if someone's deficient in something. So often I'm seeing it in people who are absolutely vegan. And then we need to maybe make sure that they have enough vitamin B complex, and then there's certain triggers. So say, for example, they may need a really good multivitamin, and I mean a good multivitamin. And then some triggers make it worse. So things like citrus, so tomatoes, oranges, etc., tend to make it not only seem worse, but also flare up a little bit more and become a little painful. So there's no treatment per se, other than just making sure that all your vitamins and minerals are supported and that you avoid certain triggers. Also, there may be a link somewhat to if you've changed your toothpaste, for example, or a mouthwash. So just check some very simple things, and that should bring the incidence down somewhat.
Thanks. Because my son, we used to use Sensodyne original, because there was something in there which is not in that toothpaste, whereas all the other toothpaste have it. I have forgotten the name, but they've stopped doing that now, so it's very difficult to find one. But that really used to help as well. But I don't know what ingredient there was, which is in all the other toothpaste, but not in Sensodyne original. But they don't do it anymore.
Okay, I'm sorry, I'm no great expert on the content of toothpaste, but I know that there is a clear link, and I think there'll be something like a bit of a trial and error story with you. But essentially, you want to be staying away from highly flavored toothpastes.
Yeah.
All right, you can look on Amazon. They've got a lot of mint-free options that with fluoride, which is what you need as well. Thank you.
Yeah, thanks a lot.
Thank you. We've got another question from Mr. Ashok Malde. And before I ask him to unmute, I've never heard of the term geographical tongue. And I probably would say that a lot of other people would not have. In a couple of sentences, Leigh-Ann, would you be able to explain what geographical tongue is?
I can. I think I'm probably best to show you. Geographical tongue is something that's often diagnosed by a dentist. It almost looks like a snail's mark, where you have some areas of redness and some of whiteness. It's usually an incidental finding. Very few people will come in and say, oh, my tongue is sore. But I will find a picture if you maybe want to have a little look, Mr. Malde.
Okay, yes. Okay, I'm going to ask him to unmute. Okay.
Hello, Umesh bhai.
Hi, Ashok bhai. Yes.
How are you? Okay.
I'm fine, thank you. Yes. Your
I'm
question?
sorry, I've just, I don't know what button I've touched. The hands come up.
Oh, okay. All right. In that case,
I'm
I'll
really
mute you
sorry.
again. That's fine.
Yeah.
I'll mute you again. No worries. Thank you.
All right, just give me 1 second and I will just show you, if I may. So this is geographic tongue, essentially. And it's an incidental finding mostly, where there is areas of redness and areas of whiteness around it. Yeah. And this can move why they say geographic, because today this little twirl may be here and then tomorrow it's on the other side, for example. So most people who have this condition become aware of it because they've seen the dentist, and once they've seen the dentist, they know what it is. But it has times where it's quiet and times where it flares up a little bit. And this is essentially what we see. The first thing I ask people is about their diet, making sure they have a balanced diet, as well as if they're, for example, deficient in anything, you just try and supplement that, and then tell them to avoid very strong triggers like citrus, as well as certain toothpastes. Okay.
Great. Okay. Thank you. Thank you, Leah. Appreciate it. I think that's it. No other questions. Thank you so much. And
very welcome.
yes, have a lovely afternoon. Leigh-Ann.
Thank you
And
to everyone for being patient. And I hope that you had a little bit of insight. Some things may be new, some may be boring, but now you all know.
it's great. It's great because I think, the key takeaway for me really is that regular visit to the dentist, to the hygienist, is always going to get an early detection of any issues that are happening.
Absolutely. And it's certainly important to keep young and healthy, because if we eat well, we can keep well. I'm a great believer in that. So we want to keep everyone eating well and healthy and staying long and having a good and a healthy long life. Take care.
Thank you so
Bye-bye.
much, Leigh-Ann. Thank you.
You're very welcome. Be all. Bye-bye.
Bye.
Take
Bye.
care.